Ma'am, it is live now. Ma'am. I'll give a small intro.
I'm sorry, I can't hear.
Can you hear me, ma'am?
Yeah, I can hear you. Can you please repeat that just a bit loudly?
Yes, ma'am. We'll start the live session now, ma'am.
We'll start.
I'll just give an intro and you can proceed, ma'am.
Sorry?
I'll just give an intro, ma'am. We'll proceed.
All right, okay. Just tell me when.
Okay. Yes, ma'am. We'll start now. Very good evening to one and all present here who have joined us through medicine. And I apologize for the delay due to some technical issues. Now we have with us Dr. Shafeequa Jamaal, ma'am, Senior Resident, Department of General Surgery, Sri Lalitambikai Medical College. She is here to take about gallstones. Thank you for joining medicine, ma'am. We welcome you, and the session is all yours. Yes, ma'am. You can.
Thank you, doctor. So, hi everyone. I'm Dr. Shafeequa. I'm a general surgeon. So today we'll have a short course on gallstones. So as you know, we're going to have a lot of interactive questions. So even though it is not a completely interactive session, I would really appreciate if you would like put your answers down in the chat box below, or if you just note down the questions and like try to figure it out yourselves, it'll be good for you too. So this is a very famous sign, well related to the gallbladder. I'm sure you'll know it. So I hope you'll put in the answers there. So we'll start off with a very initial recall. So the question goes like the injury to the right aberrant posterior sectoral duct with bile leak according to Strasbourg categorization of bile duct injury is. So there are 4 types. So anything in surgery always starts with surgical anatomy. So we will start with a bit of surgical anatomy and physiology and then move on to the gallstones. So to start with, the liver has 8 segments. So since we're talking only about the gallbladder, I'll stick only to the biliary anatomy. So we have two bile segments. That is, one is the extrahepatic biliary system, I'm sorry, and the intrahepatic biliary system. So this is the intrahepatic biliary system, and this is the extrahepatic biliary system. So the intrahepatic biliary system, so it is important to know the intrahepatic biliary system because the bile starts flowing from the liver and it starts from the hepatocytes. It starts from the hepatocytes to the biliary canaliculi, and then it comes to the portal triad, and it forms the bile duct, and it comes to the portal triad, and all these small all these small bile ducts, they come and coalescence to form these sectoral ducts. So this is the sectoral duct of the right side, and this is the sectoral duct of the left side. So this is the right posterior sectoral duct, which is curving this way, and this is the right posterior, and this is the right anterior sectoral duct. So the right anterior sectoral duct has actually a more linear pathway. There's a horizontal pathway, whereas when you can see the posterior sectoral duct has a curved pathway. So the segments, so this is 5, 6, 7, 8 is supplied by the right hepatic duct, and the left segment is supplied by the left hepatic duct. So the main thing we have to notice in this, the left hepatic duct has a completely transverse. It goes behind the 4th segment and it has a transverse course. Whereas the right has a bit of a curved course, especially in the posterior segment. So when this anterior and the posterior segment join together here, this forms a relatively shorter right hepatic duct, whereas the left hepatic duct is relatively long. So this confluence of the right hepatic duct and the left hepatic duct causes your common hepatic duct. So this common hepatic duct comes down and joins with the cystic duct, which comes from the gallbladder to form the common bile duct. So the question was basically, why is there a leak? And why is there a leak and from where is it? So these are the anatomical aberrations of the right posterior sectoral duct. So these are the different anatomical variations. And based on this anatomical variation, we can see that. So in A, so we have 2 classifications. One is bismuth, which is used for stricture classification, and Strasbourg, which is used for injury classification. So whenever there's a cystic duct leak from only the small ducts in the liver bed, that is called type A. So when there is an occlusion of the aberrant right hepatic duct, that is type B. So our question was asking a leak from the aberrant right hepatic duct. So the answer is type C. The other type is type D. So there's a lateral injury. If you can see, there's a lateral injury to the common bile duct. You can see that it extends from above to down. And so this E1, E2, E3, E4, and E5 also is similar to the bismuth classification. So for easier understanding, I have put in this type of a classification for you. So you can easily understand this. This is the common hepatic duct, which is around 2.5 centimeter. So when the injury is away, more than 2 centimeter away, it is type E1. E1 of Strasbourg, and it is within 2 centimeters from the confluence. So the confluence is the main thing that we see here. So if it is within 2 centimeters, it is type E2, right? And so when the hilar structures is preserved by the confluence, it is type 3. But the hilar system, when it is involved, it is type 4. So when the stricture is involving an aberrant right hepatic duct and the common hepatic duct, it is type E5. So that is the answer for so type C is the answer for that question. So moving on to some more of anatomy. So this is important mainly during the laparoscopic cholecystectomy. So this is the undersurface of the liver. So undersurface of the liver has something called the hilar plate, that is the porta hepatis, where all the main vascular structures enter into the liver. It is like an opening to the liver, which has the hepatic artery, portal vein, and the bile duct. So it is an extension of the Glissen's capsule. So when the hilar plate is lowered, you can see that the vascular structures will move away. So this allows for the exposure of the extrahepatic biliary tree. So this helps in easy access of the proximal extrahepatic biliary tree. This is one more update that has come in this 20th edition of Bailey. So R4U line. So when you see this image, you can see this is the undersurface of the liver if you're not able to make it out. And this is a Rovius sulcus. So this is a Rovius sulcus. This is used as an indicator during dissection of the gallbladder, mainly the cystic duct and the cystic artery. So a line which extends from the superior sulcus. So this is the Rovius sulcus here. So a line which extends from the superior border of the Rovius sulcus and extend up to the superior surface. This is a segment 4. That is the quadrate lobe, which extends. So R4U line till the umbilical fissure. So this line can be used as an indicator. So B-safe concept is something newly introduced into laparoscopic cholecystectomy surgeries. So this picture is from such a surgery. So that's why they've given this, all these BA. I'll show you later what it means. So this line, so when you dissect, so ventral to it, this region is a safer zone of dissection for the cystic duct and the cystic artery. Whereas this region, you have to stop your dissection post this line because you may injure the CBD beyond this, right? So coming to the gallbladder proper, the gallbladder part has 4 parts, mainly the fundus, the body, the neck, and this is a dilatation or outpouching in the neck called the Hartmann pouch. Whenever a stone is formed, it is more common to lodge in this place. So the size of a gallbladder extends from 7.5 to 12 centimeter. So this is according to the new Bailey, but Sebastian says 7 to 10 centimeter. And the Bailey says 25 to 30 ml is the capacity of the gallbladder, but Sebastian says 30 to 60 ml. But I've mentioned this because this is the recent update for undergrads. This is so much better. And the main thing in the histology of the gallbladder is it doesn't have a submucosa or a muscularis mucosa. And plus, you can see these dilatations of the mucosa inside. So these are called crypts of Lushka or the Rokitansky-Ashkoff lines of Lushka. They are dippings of the mucosa up to the muscularis propria. So from the gallbladder, the bile enters into the cystic duct. So the cystic duct is approximately 1 to 5 centimeter long and it has a lumen of 1 to 3 millimeter. And it has these spiral folds, which are called as the valves of Hester. They're not valves of Hester. They're not typically valves, but they are mucosa, which are arranged in a spiral pattern. Even though they're not typically valves, they manage the outflow. They act as a sphincter to the outflow of the bile from the gallbladder. And there is also a sphincter of Lutkin's, which is not a typical sphincter, but is the thickening of this muscular coat around the cystic duct. Right. So the very famous Callet's triangle is here. Sebastian mentions only Callet's triangle, but the New Bailey also mentions the hepatobiliary triangle and the Callet's triangle. It is the same thing, but only thing, a single margin, that is a single border will change. In the hepatobiliary triangle, the superior margin is formed by the inferior border of the liver. This side is the common hepatic duct and it is the cystic duct inferiorly. The only difference is in the Callet's triangle, right, the cystic artery forms the superior border. Basically, the hepatobiliary triangle, the Callet's triangle, the contents are 3. You have to remember 3 things. One is the artery, which is the main reason it is used. It is important for. The next is the Callet's node, also known as Mascagni's nodes. and that is the sentinel node of the gallbladder, and fibrofatty tissue which is present. So the main thing with the cystic duct is it may have multiple anomalies which you should know, especially when the patient is going in for a laparoscopic cholecystectomy. So this is the normal anatomy of a cystic duct, which joins the common hepatic duct to the CBD. It is a bit lower, it is attaching a lower way, and it may be a parallel attachment to the common hepatic duct. In this, the cystic duct is absent. In this, it is directly going and attaching to the right hepatic duct. In this, it is inserted into the biliary confluence. So from the cystic duct, the extrahepatic biliary system continues this common hepatic duct, which is 2.5 centimeter. Along with the cystic duct, when they coalesce, they form the very famous common bile duct, the CBD, which we call. The CBD has 4 parts. One is the supraduodenal portion, the retroduodenal portion, the infraduodenal portion, and the intraduodenal portion, right? So, and this CBD, it continues and it opens into the second part of duodenum through the major duodenal papilla. So here the ampulla of water. Ampulla is nothing but a reservoir where the duct opens. That is the CBD also opens, the pancreatic duct also opens. And there are sphincters here if you can notice. So there's a sphincter here, there's a sphincter here. So ampulla of water is also called as hepatopancreatic ampulla. So there's a hepatopancreatic sphincter here, which is very famously known as the sphincter of Oddi. So the main importance of the sphincter of Oddi is it is always in a contracted state. So whenever the bile comes in from the liver, due to this resistance, it does not come down this way. It goes and sits in the gallbladder, and only when the patient is fasting or has taken food and has taken a fatty meal, and the fatty meal crosses from this region, so cholecystokinin gets released. This cholecystokinin causes contraction of the gallbladder and the relaxation of the sphincter of Oddi, and then the bile passes through. So the vascular anatomy is mainly the arterial supply is from the abdominal aorta, which gives the celiac trunk. And from the celiac trunk, we have this common hepatic artery. The common hepatic artery, after giving the gastroduodenal artery, becomes the hepatic artery proper. The hepatic artery this is the right hepatic artery. The hepatic artery gives the right hepatic artery and the left hepatic artery. The right hepatic artery is usually the most common source for the cystic artery, which supplies the gallbladder and the cystic duct. So this is the normal anatomy of the right hepatic artery. In some instances, what happens is in this Callet's triangle, you can see that there is a tortuous vessel that you can notice. This tortuous hump of the vessel, that is the hepatic artery, is known as Moynihan's hump. So when we are dissecting during laparoscopic cholecystectomy, if you are not aware of this anomaly, there may be a lot of bleeding that we have to endure. So this is the venous drainage of the gallbladder. It is mainly drained by the cystic vein, which drains into the portal vein. The neck mainly drains into the portal vein directly, whereas the body and the fundus, they also drain into the hepatic sinusoids. So coming to the next question. So a patient had a trauma to the liver and you are doing a Pringles maneuver. So which you'll do to control bleeding in that time. So during the procedure, you're seeing a pulsatile vessel on the lateral aspect. What is this vessel? So the answer is accessory right hepatic artery. So in 20% of the people, accessory or replaced right hepatic artery passes through the portocaval space and ascends to the right lobe of the liver along the lateral aspect. On CT, you can see a vessel. It passes between the portal vein and the inferior vena cava behind the head of the pancreas. So the gallbladder lymphatic system is from the subserosal and the submucosal layers, respective plexus are formed, and they move into mainly the sentinel node is the cystic node, that is the Mascarenhas node, and then from the Mascarenhas node it moves on to the pericholedochal nodes and to the posterior pancreaticoduodenal nodes and the superior pancreaticoduodenal nodes. But in sometimes the subserosal nodes also directly drain into the hepatic region. It directly drain into the liver. So sometimes in gallbladder, that is one of the reasons that there is metastasis to the liver very early in CA gallbladder. So nerve supply to the gallbladder, sympathetic is by the hepatic plexus, parasympathetic is by the vagus, and the pain sensory is also through the vagus. Main supply is for the release of the cholecystokinin. So what is the false statement about bile salt and bile flow? So Cholic acid and deoxycholic acid are formed from cholesterol. The secretion of bile components into biliary tree is a major stimulus for bile flow. Bile salts possess osmotic activity, and bile osmolarity is equal to plasma. So how is bile produced? So this is a hepatocyte. So the hepatocyte secretes that. So bile consists of not only bile pigments, it also consists of bile salts, phospholipids, and cations, which is there, and water. So the bile salts, they secrete, and the hepatocytes secrete the bile into the biliary canaliculi. So these biliary canaliculi, they form bile ducts. So these bile ducts come and join this portal triad. So this 5 or 6 of this forms a hepatic lobule. So the hepatic lobule is one of the functional units of the liver. So after it comes, this you can identify it with the central vein, right? So from there, the bile ducts coalescence and form the right and left hepatic duct, which forms the common hepatic duct. So basically, the bile salts, they are created from cholesterol. So bile salts are synthesized from cholesterol, and the bile consists of bile salts and bile pigments and everything. So that itself acts as an osmotic process. It sucks in water in it, and it tries to move in through the flow of the biliary tree. So what happens is all these bile salts, they combine together to form spherical pockets like micelles. With cations. So the anions with cations, and they are then secreted to the biliary tree. So this causes an osmotic load to happen, and it draws water into the duct and increases the flow. This also helps to keep the bile neutral and saves the hepatocytes from damage from the bile. So, and because it's neutral, it is comparable to that of plasma. So amount of bile salts, what is the amount of bile salt that is lost in stools? So it is around 5%. For that, you have to understand the enterohepatic circulation. So how bile is produced? So first, when the erythrocytes, that is the RBCs, are damaged, the hemoglobin breaks into heme and globin. This heme gets reduced to bilirubin by heme oxygenase, and then it forms bilirubin. This bilirubin is carried on to the liver through albumin. This is an unconjugated bilirubin. When it comes to the liver, it gets conjugated, and this conjugated bilirubin it travels through the bile, and travels through the bile. And when this bile goes from the gallbladder through the common bile duct through the duodenum, and then it goes to the ileum, when especially in the terminal aspect of the ileum, again it gets reabsorbed. Almost 95% of it is reabsorbed. Only 5% is left. And the 5% gets excreted by as urobilinogen or as stercobilin. Stercobilin goes in feces. That's what gives the color of the feces. Right? So the answer is C, 5% get reduced. If a lot of bile salts reach the colonic lumen, it is a huge powerful detergent activity. It can cause inflammation and diarrhea. That is why in post-cholecystectomy, because there is no storage, so main function of the gallbladder is storage. So post-cholecystectomy, since there's no gallbladder to cause the storage, the speed of the enterohepatic circulation increases, and it overwhelms the ability of the terminal ileum to absorb bile salts. So more bile salts go to the colonic lumen, and it may cause inflammation and cause diarrhea. So post-cholecystectomy diarrhea, this is the reason for it. So one more question we'll have. So regarding the hepatic bile that enters the gallbladder, what is the wrong statement? So increased cholesterol and calcium concentration happens in GB bile, correct? And 10 times concentration happens. Sodium and water are absorbed and concentration happens. Bicarbonate is secreted. Bicarbonate is not secreted in the bile. So the gallbladder basically, we'll come to the physiology, we're coming to the physiology now. It's basically an extrahepatic storage site, and it absorbs the water, sodium, and bicarbonate, and it concentrates the bile concentrated bile through the active sodium transport. The gallbladder also by itself secretes 2 ml of mucus per day. That's why when there is a healthy gallbladder, but there's an obstruction and the neck of the gallbladder, a lot of mucus is secreted. So it forms a mucocele. This is because the gallbladder by itself secretes mucus. And so what happens is all this water, sodium, and bicarbonate get reabsorbed, right? So there is increase in the cholesterol and the calcium concentration. So this decreases the stability of the cholesterol vesicles. So when there's a decreased stability, always there's a predisposition to something. So whenever there's a decreased stability, the nucleation of the stagnant pool of cholesterol. So this forms like a nidus for a stone to form. Plus what happens is the neck of the gallbladder. So when you have the gallbladder this way, so you have the gallbladder and the cystic duct. So this neck of the gallbladder in this region also secretes glycoproteins to help the gallbladder protect the detergent activity. So this excessive secretion also promotes crystallization of the cholesterol. Just a clinical scenario for you. So there's Mr. X who has had several gallstones, which is measuring 12 mm, and their serum bilirubin, ALP, and GGT are all elevated 5 times above recommended level. So what is the next line of action? You will come to this only when you understand the basics. So gallstones, we're starting with the topic proper. So the incidence is around 10 to 15%. They're asymptomatic in the majority of cases, and most of them are usually identified only incidentally. So approximately in this 80%, only 1 to 2% per year will develop symptoms. But even that makes for a huge population. Hence, laparoscopic cholecystectomy is one of the most common surgeries performed. So the stones that we have are of three main types. One is cholesterol, pigment, and mixed stones. Why it main types? Because it depends on the principal solute that precipitates into stone. So this is a cholesterol stone. This is a GB filled with cholesterol stones. So in the USA and Europe, 80% cholesterol and or mixed stones are more common, whereas in Asia, pigment stones are more common. So in cholesterol stones, 50 to 99%, it is made of pure cholesterol. Plus, it is made of calcium salts, bile acid, bile pigment, and phospholipid. In pigment stone, so the center one that you can see is the pigment stone, and these are the mixed stones. So the pigment stones can be black as well as brown. So we'll start off with the black. So the black stones are exclusive to the gallbladder, and they form only 30%. They have only 30%, less than 30% of cholesterol. So in pigment stones, 20 to 30% stones are black, and the incidence rises with age. And even patients with cirrhosis seem to have a higher incidence of pigment stones, but the cause is not really known. And so how it happens is insoluble. It happens mainly in hemolytic situations like hereditary spherocytosis and sickle cell. So whenever there's increased hemolysis, you know that I've already told you that there's a lot of bilirubin that gets secreted. So whenever there's a lot of bilirubin that gets secreted, this insoluble bilirubin, because it is unconjugated bilirubin, excessive bilirubin, only a certain amount will get conjugated in the liver. But when there is excessive, the insoluble bilirubin that results from it, it mixes with the pigment polymer, mixes with the calcium phosphate and calcium bicarbonate, and that forms the black colored pigment stones. The next kind of stones are brown stones. So they are more common, not in the gallbladder. Like how the black stones are more common in the gallbladder, the identifying feature, if you have a question and you want to clear out if it's a black stone or a brown stone, is these are more common in the bile duct, more common in the bile duct. And they're made of calcium bilirubinate, calcium palmitate, calcium stearate, as well as cholesterol. So it is mainly related. So the pathogenesis of this, like we have hemolysis for the black stones. For the brown stones is mainly the stasis of bile. Anywhere there is stasis, there is a nidus, there's a stone formation. So whenever there's a status, and infections also secondary to deconjugation of bilirubin glucuronide by bacterial beta glucuronidase. So whenever this happens, insoluble unconjugated bilirubin precipitates. So on not only stones, it is associated with the presence of foreign bodies also within the bile, like when we place stents or parasites of the hepatic system, like the Clonorchis sinensis or the Ascaris lumbricoides. So what is the answer for this now? What is the stone that is formed exclusively in the gallbladder only? I'm sure you know the answer. It is black pigment stones. And so this question is, cholesterol stones are formed due to nucleation of cholesterol from dash multilamellar vesicles. So you may think all of this is, these are all questions that are going to come, and only when you understand the basics, you will be able to answer this. So the answer for this is mononucleate crystals. So this nucleation of cholesterol from the multilamellar vesicles is a crucial step in the formation of the gallstones. This happens crucial step because of the nidus formation, and then also when there is abnormal emptying of the gallbladder. So there will be stasis. So when there is stasis, obviously the formation of the stone will increase. Plus pronucleating agents, like I mentioned, from the neck, the glycoproteins and the immunoglobulins. When the concentration of the vesicle exceeds the solubility of cholesterol, that also relates to formation of the stone. And it is further so bile stasis, some of the reasons for bile stasis that you can see are fasting, when you give total parenteral nutrition, vagotomy, octreotide drugs, they all can cause cholesterol type of gallstones. So this is the physiology behind the formation of gallstones. Mainly, there's an impaired gallbladder function. So the emptying is decreased, or the absorption is reduced, or the excretion is impaired, or the bile is supersaturated. So the very famous female 40 fat fertile, that category comes into the supersaturated bile. So the age, sex, genetics, obesity, and diet. The other main heading under which the gallstones form is absorption, or there's a difference in the absorption of the intrahepatic circulation of the bile acid. So we saw the intrahepatic circulation anywhere where there's a block, so that causes a negative effect. So especially when the patient has an ileal resection, there is no absorption and there is no complete passage of the bile. And even in those conditions, there will be a formation, because when the bile acids, especially in ileal resection, when you see when the terminal portion of the ileum which absorbs the bile salts and the bile acid is lost, so there'll be decreased bile acid and bile salt. Only when there is sufficient bile salt and bile acid, the vesicles will remain in that proper micella state. Otherwise, cholesterol will increase and it will form a nidus and form a stones. So cholesterol nucleating factors, like already mentioned, mucus, glycoprotein, and infection. So main thing is increase in cholesterol, decrease in bile acids, decrease in inhibitors like lecithin. This happened, there are two mutations which are related to gallstone disease. One is MDR mutation and one is CYP7A1 mutation. So this decreases bile salt production. The fifth one is fibrate therapy, clofibrate therapy, and also decrease in cholecystokinin. So only when there's cholecystokinin, the gallbladder will start releasing and working, functioning properly. So whenever there's a decrease in cholecystokinin, like in prolonged starvation or TPN or truncal vagotomy, there's decrease in starvation, there is no contraction of the gallbladder, and there is stasis. So just a reminder, the correct composition of brown pigment stones is option C. So what happens when the patient has gallstones? Usually they're asymptomatic, and it's usually detected incidentally during when they're imaging regularly. So nowadays, a lot of people go for master health checkups. So they just find out gallstones in that time. But some people, they do present with symptoms. So they have right upper quadrant or epigastric pain, which may radiate to the back, even though it is called a colicky, that is biliary colic. It is not typically a colicky pain. It is dull, continuous, and severe. It lasts for several minutes or hours, and it's associated with nausea and vomiting. So it starts more in the night, because the patient is fasting then. So it starts more in the night and kind of awakens the patient. During the day, they have intermittent symptoms. In majority, what happens, the patient has pain for some time and then they get relieved because the stone might have been in the neck and it slips back into the body. So ultrasound is the initial investigation of sound. So you can see in this ultrasound, these are the stones. So you can see a hypoechoic gallbladder, a hyperechoic stone, and this is the posterior acoustic shadowing, right? So in bloods, so obviously you'll always start with blood investigation. So you can, so the bloods in simple cholelithiasis will not be deranged. The LFTs will not be deranged. But if you see cholelithiasis with a deranged LFT, that is the bilirubin is increased. You have to see if it is a direct bilirubin is increased or an indirect bilirubin is increased, and the ALP is increased. Then you have to suspect something called a cholelithiasis. That means the stone is in the bile duct now. That is a common bile duct now. So for that, we have to do an investigation called an MRCP. So we have a routine set of investigations, especially imaging, that we do. One is ultrasound, MRCP, and MRCP is pretty gold standard, but it is only for diagnostic procedures. But post MRCP, we have ERCP, and only we'll do a CT abdomen and gallbladder when we are suspecting some complications such as perforation. So this is an plain radiograph which shows multiple radio-opaque stones. This is the famous Mercedes-Benz or seagull sign, and this is an MRCP image. I'm not sure if it's clear for you there. So you can see these multiple stones in the gallbladder. Even in this image, this is also an MRCP. You can see this. That is a cross-sectional view, and this is a cross-sectional view. And here you can see the stone. So apart from the pain, the associated symptoms that you can have with gallstones are dyspepsia, flatulence, fluid intolerance, and particularly to fats, and some alteration in the bowel frequency. So what happens, repeated episodes of pain can result in a non-functioning gallbladder with the development of chronic cholecystitis. So main thing, asymptomatic patients, there's been a longitudinal study which they've taken, which they've done, and only they've noticed that 20 to 30% of asymptomatic patients will develop symptoms within 20 years, and approximately only 1% of them will develop complications. Hence, this dictum, please remember, prophylactic cholecystectomy is not warranted in asymptomatic patients. So non-operative treatment of gallstones, not very, it doesn't really work completely, but you can try them. Like oral bile salts can be given, HMG-CoA reductase inhibitors, contact dissolution with organic solvents by cannulation of the gallbladder, but the recurrence rate is 50%. And ESWL, extracorporeal shockwave lithotripsy, can be tried. It has a recurrence rate of 20% and is used only in stone size from 0.5 to 2 centimeter. So coming to the complications and effects of a gallstone. So first is pain because of the biliary colic. So what happens is when we take in the gallbladder this way. So forgive my drawing. So this goes into the
Ma'am, am I audible?
duodenum, right? Right. So when the gallbladder gets stuck here, so it may cause an acute inflammation of the gallbladder, that is acute cholecystitis. And repeated attacks of acute cholecystitis will cause chronic cholecystitis. And when you let it progress further, there may be a purulent collection which causes an empyema of the gallbladder. And when the stone gets stuck in the neck, excess of mucus production, which I already showed in the initial phase, excess of mucus production can cause a mucocele to form. And whenever there's a empyema of the gallbladder, the wall may undergo necrosis. And due to inflammation, the wall may go necrosis and perforate. So perforation of the gallbladder may occur. So these are complications related to the gallbladder. So next, what happens is when the stone starts traveling. So one of the indications is when the stone is at this neck junction, it starts pushing. So we have something called a Mersey syndrome. So whenever this structure, so the lumen of this CBD is pretty narrow. So when a large stone obstructs this region and starts pushing, that time we have something called a Mersey syndrome. When the gallstone goes down into this passage, and it causes an obstruction in the near the ampulla of water or anywhere for that reason. So you may have an obstruction to the flow of bile. So you may start to see jaundice in the patient, which is called as obstructive jaundice. Next, inflammation of this region after the stasis. So first is stasis causing of the obstruction, and then infection, because stasis is always followed by infection. So cholangitis. So the inflammation of the bile duct is called as acute cholangitis. So this stone will next go through this to the pancreas, blocks this duct here, may cause pancreatitis, or the stone may cross from here, it may go into the bowel. So when it goes into the bowel, it goes right to the terminal ileum. There it may go and cause obstruction, which may cause intestinal obstructions. So this is an easier way to remember all the effects and complications of gallstones. So coming to another question, acute cholecystitis. So what is the false statement? So ultrasound is 85% sensitive and 95% specific. All cases are confirmed by HIDA scan. A CCT is less sensitive than ultrasound, and pericholecystic fluid is seen in ultrasound. So the answer is B. All cases are not confirmed by HIDA scan. So HIDA scan is basically a nuclear medicine imaging. It is used to demonstrate the obstruction in the cystic duct. So whenever the dye is injected, you can see the entire, it is excreted through the bile. So the entire biliary flow can be seen. But whenever there's an obstruction, it may be used to demonstrate, because there'll be no flow. So you can realize that there's an obstruction somewhere. So whenever the gallbladder is not visible, it is a definite diagnosis of acute cholecystitis. But the filling eliminates the diagnosis of cholecystitis. CT is less, actually comparatively less sensitive than ultrasound for acute cholecystitis. So coming to acute cholecystitis, the first picture that we saw, that was Murphy's sign. So right upper quadrant tenderness exacerbated during inspiration by palpation in the right subcostal region. So why is there, and the pain is referred to the shoulder. The pain is referred to the shoulder because the phrenic nerve root is C5 and the supraclavicular root nerve is C4, C5, C6. So they share a C5 common term. So that is why you have pain in the supraclavicular, right shoulder also. So the patient acute cholecystitis. So there is an itis here. So obviously the patient is going to have a fever. If a mass is palpable, it may be due to, because the gallbladder is inflamed, the omentum always comes in. Omentum comes as a friend there. So the mass may be palpable as the omentum walls of the inflamed gallbladder. If the cholecystitis is resolved with antibiotics, it is well and good. If not, it may form into an empyema gallbladder. So this empyema gallbladder, when there's abscess, so the walls may become necrotic and perforate, and they may develop localized peritonitis. So the investigations that are more sensitive are the HIDA scan, followed by CT, followed by ultrasound. Investigation of choice in acute cholecystitis is ultrasound. Why? Because the HIDA scan only shows a physiological pathway. It doesn't really show all anatomical defects. So Courvoisier's law. Right now, I had told that a mass may be palpable here, but in acute cholecystitis, the derangement of the LFTs will not be excessive. Whereas if it is a palpable, non-tender gallbladder with jaundice, it is unlikely be due to stones. Right, it may portend a more sinister diagnosis as a palpable gallbladder, and the presence of jaundice is unlikely due to gallstones and usually results from a distal common duct obstruction, which is secondary, most commonly due to a periampullary malignancy. There are also there are obviously always something away from the rule also. So faults regarding the use of HIDA scan. So failure of filling of the gallbladder after 2 hours of the meals implies acute cholecystitis. So this is correct. Mainly used to study the anatomy and physiology of bile flow. This scan cannot identify the gallstones. Investigation of choice for biliary dyskinesia. So the answer is right. The first, failure to fill the gallbladders after injection demonstrates the obstruction of the cystic duct, identifies the obstruction of the biliary tree and the bile leaks, which may be useful in post-operative setting. Gallbladder function. So the injection of, you can also assess the gallbladder function by this. When you inject cholecystokinin, you can document the physiological ejection of the gallbladder. It only demonstrates physiological flow, but does not provide anatomic details. So it cannot identify gallstones. Right. So the answer is C. So in acute cholecystitis, how will you say it's acute cholecystitis? So there's a Tokyo consensus which gives the guidelines for diagnosis. So there must be local signs of inflammation, that is Murphy's sign, or right upper quadrant pain, tenderness, or mass. Systemic signs of inflammation, that is fever, elevated CRP, or elevated WBC counts, and imaging findings which are characteristic of acute cholecystitis. So characteristic of acute cholecystitis imaging findings is a thickened gallbladder wall, pericholecystic fluid. You can see the gallstones there. So how will you classify the cholecystitis, if it is mild acute cholecystitis, moderate acute cholecystitis, or severe acute cholecystitis? So in mild, they have just said that it does not meet the criteria of grade 2 or grade 3 cholecystitis. So basically, grade 1 cholecystitis is just acute cholecystitic features in a healthy person, with they should not have any organ dysfunction or just mild inflammatory changes. But in grade 2, you have 4 components. You can remember the term W, I, T, and D. So elevated white cell count, there's a palpable tender mass, and the duration is 72 hours, and local inflammation. So WBC, the W stands for the elevated white cell counts. This is marked local inflammation. Marked local inflammation as in if there's a gangrenous cholecystitis or there's an abscess there, there's a peritonitis which is happening. And this P stands for a palpable tender mass if it's present, and the D is if the duration is greater than 72 hours. White can be used as a mnemonic for grade 2 acute cholecystitis. Coming to severe acute cholecystitis, this you can easily remember when you can start from head to toe. So first off, when you start off with head, you can remember that whenever the patient is sick, start from head to toe. So neurologically, what will happen when the patient is sick? They're usually drowsy. So decreased level of consciousness. Next, go to the heart. So whenever the patient is sick, there's usually hypertension. So in this cardiovascular dysfunction with hypertension, it requires treatment with dopamine greater than or equal to 5 mics per kg per minute or epinephrine. Next to the heart is the lungs. So the partial pressure, the fraction of the partial pressure of oxygen and fractional inspired oxygen, the ratio should be less than 300. Then you have to come to the liver. So any early acute liver dysfunction is always indicated by PT-INR. So when the PT-INR levels are greater than 1.5. Renal dysfunction, decrease, everything is decreased. So neurological function is decreased, decrease in concentration, cardiovascular function is decreased, hypertension, respiratory dysfunction, the fractional inspiration oxygen is all reduced, hepatic function, PT-INR is increased, renal dysfunction, oliguria, decreased urine, and the creatinine is elevated, like greater than 2. And in hematological dysfunction, the platelet count comes down, less than 100,000. So initial non-operative treatment in acute cholecystitis, keep the patient nil by mouth and start intravenous fluid administration until the pain resolves, give him adequate analgesics and antibiotics. But when you're giving antibiotics, keep in mind that usually the cystic duct is blocked. So it may not consider, so bile, the antibiotics that secrete in the bile may not be very much feasible in these situations. So it is rather, you can choose an antibiotic that will concentrate on the serum. So a broad spectrum antibiotic, which is effective also against gram-negative aerobes, is more preferable, like cefazolin, cefuroxime, or ciprofloxacin. And then subsequent management, you will take it as you go based on the patient. So this is a new update in the Bailey 28th edition, where they have given pathways on how you manage acute cholecystitis, the grade 1, grade 2, and grade 3. Grade 1 is simple. You give antibiotics, general supportive care, and you plan the patient for an early laparoscopic cholecystectomy. In grade 2, you give antibiotics and general care. And if the patient has come in early, you can do an urgent or an early laparoscopic cholecystectomy. That is within 5 to 7 days. If not, if the patient's general condition is poor, you can do an early GB drainage or an urgent or an early GB drainage, and then move on to a delayed or an elective laparoscopic cholecystectomy after 6 weeks. In grade 3 severe, in everything you will give antibiotics and general care. So in grade 3, when it is severe, there are no negative predictive factors, and you have a good center. It is an advanced center with a good surgeon who is very well versed in laparoscopic cholecystectomy. You can try the pathway for an early laparoscopic cholecystectomy. If not, the negative predictive factors are present, then you can try for an early GB drainage, that is cholecystostomy. And then if the performance score, so all this is mainly assessed by the performance score. So if there's a good performance score of the patient, you can do a delayed or an elective laparoscopic cholecystectomy. But if the performance score is still poor, you have to keep the patient on observation and plan for subsequent management. So this new term has been introduced in the 20th edition, that is the Charlson's Comorbidity Index. It has a multiple parameters, and the main scoring greater than 5 indicates a severe thing. So in this question, it's asked that the Charlson's Comorbidity Index less than 5 with antibiotics controls the inflammation. So according to the Tokyo guidelines, what will you do? So the answer is early cholecystectomy, because the performance score is, because the morbidity index, that is the performance score, is better and the morbidity index is less, then you can plan for an early cholecystectomy. So timing for an early cholecystectomy is, what do you think maybe the answer is? So initially they were telling it is 72 hours, but now it is given 5 to 7 days from the onset of attack is a good time. But it should be a surgeon who's experienced and excellent, and has excellent operating facilities. So moving on to the next complication of gallstone, that is chronic cholecystitis. So in chronic cholecystitis, clinical features are all except fibrosis is seen due to repeated inflammation at cystic duct and gallbladder. 50% of patients only have typical biliary colicky symptoms. Colicky pain is a misnomer. Pain lasting 24 hours or more implies there is development or acute episode. Vomiting and nausea are never seen. So the answer is usually E. So obviously only 50% report pain with the foot, and mainly the pain is in the right upper quadrant or the epigastrium. The misnomer I've already explained. It is usually a constant pain and lasts a few hours. When it is associated with a longer pain of 24 hours and associated fever, you have to understand the chronic cholecystitis may be into acute cholecystitis. Also, it may be associated with other symptoms like bloating, nausea, and vomiting. So ultrasound has a typical mnemonic that you may remember that says the West mnemonic. So the wall thickness is greater than 3 millimeter, has an echogenic shadow and a post-acoustic shadow. So plan is an elective cholecystectomy. and you will go for observation and dietary and lifestyle changes. When there are severe or recurrent symptoms, elective cholecystectomy only. In acute calculus cholecystitis, when the blockage of the cystic duct is not resolved, there is inflammation and edema which happens, which leads to subserosal hemorrhage. So this changes can be graded from in a grade of 5. The grade 1 starts from this localized inflammation to grade 5 is pericholecystic abscess, which may also further move into bilioenteric fistula and peritonitis. In the infective foci, the lab values, there may be mild elevation of alkaline phosphatase, bilirubin, and transaminase level, and leukocytosis. When there is profound jaundice along with the cholelithiasis, you have to have a high degree of suspicion for cholangitis. So there's Mrs. X, who's a 73 years old post-CABG patient, complains of fever, right hypochondrial pain. Her BP is 70/40, which is low. And she's already on noradrenaline support, and she has tachycardia. Her serum creatinine is elevated, and her WBC count is elevated, and her platelet count is 40,000. What will be your plan? So in Tokyo classification, what does she come into? So she has hypertension on support. She has tachycardia, and she has creatinine level. So CVS CVS is involved, RS system is involved, and platelet count, and the hematological system is all involved. So the patient is in grade 3, severe acute cholecystitis. So what will you plan for this patient? Something called percutaneous cholecystostomy. This is a bailout drainage procedure that we do in a very, based on the status of the patient, and especially a very sick patient. So it rapidly relieves symptoms. And then following 6 weeks later, we can plan for an interval cholecystectomy. So we can drain the gallbladder by ultrasound guided drainage. So this is the next complication of gallstones. So mucocele of the gallbladder. The image is done. So whenever there's a complete obstruction of the cystic duct, so all the bile salts gets reabsorbed by the gallbladder and secretes a portion of uninfected mucus. So there's a thick mucus, dense gallbladder that is formed. The next is, like I said, the Mirizi syndrome. So when there's a large stone which is sitting in this Hartmann's pouch or near the neck of the gallbladder, it starts to compress. So this gallstone migrates from the gallbladder, it obstructs or compresses. So what happens when there's obstruction or compression? There'll be obviously infection due to the stasis. So there may be repeated attacks of cholecystitis. And when the obstruction is complete, you may have an obstructive jaundice. The patient may present with features of obstructive jaundice. And once it keeps on eroding in this wall, it may form a communication. That is, a fistula may be formed. And repeated attacks usually form fibrosis and adhesion. So these are the different grades of Mirizi syndrome, where only there's an extrinsic compression of the common bile duct. In this cholecystobiliary fistula, the gallstone has eroded only 1/3 of the circumference of the common bile duct. So a cholecystobiliary fistula has formed. In this, more than 2/3, in this 1/3, and in this 2/3, involving 2/3 of the circumference of the common bile duct has been involved. And in this, the whole circumference of the bile duct has been involved in the cholecystobiliary fistula. Here, any type of the any type plus a cholecystoenteric fistula. What is false? So next is coming from the Mirizi syndrome, we're coming to the CBD stones. So what is false regarding CBD stones? 10% of patients undergoing biliary imaging may have silent stones in the CBD. Secondary stones are formed in the GB and jump into CBD. Primary stones are common in Asians. This is true because of hemolysis and pigment stones are primary stones, yes. And 10% of patients undergoing biliary image may have a silent stone in CBD. This is also right. So retained stones are seen in 2 years after GB surgery and seen in 10 to 20% of the cases. So what is the answer? So primary stones. So primary stones arise de novo in the bile duct. So there are 2 types of stones which occur in the bile duct. There are 3 types of stones which may be seen in the bile duct. One is the primary, one is the secondary, and one is the retained stones. So primary stones which arise in the bile duct themselves, and they're usually brown in color, that's brown pigment stones. They're a combination of precipitated bile pigments and cholesterol. They're also associated with bacterial infections, where free bilirubin is formed by hydrolyzing enzymes which are released by bacteria and then precipitates. So it is more common in Asian population. So secondary, they pass from the gallbladder into the bile duct. and it is more common. This is more common in the United States. So retained stones are secondary stones which are found in the bile duct after 2 years, within 2 years of cholecystectomy. And it happens in 1 to 2% of the patients. So what is a false statement regarding cholangitis? Cholangitis is basically inflammation of the CBD. So bacteria is seen. So bacteria in the bile system is seen in 90% of the patients. Charcot striae is seen in 100% of the cases. And least common finding in Charcot is jaundice. So HIDA scan is not useful in these cases, and percutaneous drainage is done. So what is Charcot striae? So obstruction from a stone is identified in whenever there's an obstruction from a stone, bacteria is identified into 90% of the patients. And these are the common organisms that cause infection, the bacteria, the cause of bacteria. So the classic Charcot striae is fever, jaundice, and right upper quadrant pain. And it is present only in less than 50% of all the patients. So the least common finding being jaundice among the three. So the answer is Charcot striae. The answer is B. This is the false statement because only in 50% of the cases Charcot striae is seen. When you further investigate the patient usually has leukocytosis, and hepatocellular injury from the infection and inflammation causes the rise in serum transaminases level and alkaline phosphatase level. So ultrasound is the first screening test that we use, and you can see the dilatation of the biliary tree in it. And in this, cholangitis, HIDA scans should be interpreted with caution because in infection, the biliary tree reduces the secretion of these agents into the biliary tree. So you may misdiagnose also. So here, this is an ERCP image, and I am sure you can see this is the right hepatic duct and the left hepatic duct. This is the common hepatic duct, and this is the bile duct. Can you see this filling defects? So this is the CBD stones that you can see. So there's a raise in, on investigation, you can see the raise in bilirubin and ALP. The investigation of choice is MRCP, and the ERCP is both diagnostic and therapeutic. Management. So when you come into management and the case that we initially saw, so in that patient, we will do an ERCP because the liver enzymes arise, the jaundice, the patient has severe jaundice. So we will do an ERCP and we will leave this stent in situ for the jaundice levels to come down. And then we will follow it by a laparoscopic cholecystectomy after 6 weeks. If we are unable to do an ERCP, we can plan to do a choledocholidotomy for the patient, which can be either done by a open or lab. So what is true regarding the management of gallstone? So the next complication is gallstone pancreatitis. So what is true regarding the management of gallstone pancreatitis? Cholecystectomy must be done within 6 weeks. Only ERCP is sufficient to prevent future attacks. Laparoscopic cholecystectomy is done in the same admission, and intraoperative cholangiography is advised always. So in gallstone pancreatitis, the patient usually presents with features of acute pancreatitis. In this situation, only ERCP is not sufficient to prevent future attacks. And cholecystectomy must be done in 6 weeks based on the patient performance curve. But what is always advised usually in a gallstone pancreatitis is laparoscopic cholecystectomy should be done in the same admission. Intraoperative cholangiography is not always advised. So the answer is C. Usually the pancreatitis is self-limited. Early ERCP is done only to reduce the morbidity of the patient. To prevent a future episode, cholecystectomy is only beneficial, and especially in the same hospitalization just before discharge. So whenever there's a choledocholithiasis, intraoperative cholangiography can be done to confirm the passage of gallstone, but it is not always mandatory. So false regarding acalculous cholecystitis. They may not have right upper quadrant pain. Imaging shows pericholecystic fluid and gallbladder wall thickening. HIDA scan is diagnostic, and the percutaneous cholecystectomy tube replacement shows 90% improvement. Interval cholecystectomy done after 6 weeks always. So the false is, so whenever the cystic duct gets obstructed in the absence of stones, it is called as acalculous cholecystitis. So the risk factor, usually the patient is an old patient and is sick, either a severe burns or trauma or prolonged use of TPN. ICU patients, you can see acalculous cholecystitis. It presents in a more fulminant way. The patient is already sick. It presents in a more fulminant way than calculous cholecystitis, and it has a more rapid progression to gangrene of the gallbladder than cholecystitis, calculous cholecystitis. So regarding gallstones in pregnancy. So coming to gallstones in pregnancy, hormonal estrogen changes during pregnancy increases cholesterol secretion, and progesterone reduces bile secretion and cholesterol. So this is true. So due to the estrogen changes, the cholesterol secretion increases. and progesterone reduces the bile secretion. So this increases and this decreases. So this is the nidus for cholesterol stone formation. And women in first trimester are managed in conservative and mild cases. This is true. Second trimester cases of moderate or severe disease must undergo cholecystectomy. In third trimester, laparoscopic cholecystectomy is not possible, and hence open is advised. We'll explain why. So the answer is laparoscopic. It is not necessary that the laparoscopic cholecystectomy is not possible, but it is better to do surgery in the second trimester if moderate or severe disease, because cholecystectomy actually cholecystitis is one of the most common, that is second most common non-obstetric indication for surgery in a pregnant woman. So progesterone not only causes a decrease in the bile secretion, it also reduces, it slows the gallbladder emptying, so increases the bile stasis, plus pregnancy, the obesity, the pregnancy, pre-pregnancy obesity or multiparity, increasing age and genetic predisposition or other risk factors. So the investigation that you can do here is ultrasound and non-contrast MRI are acceptable diagnostic modalities. So in first trimester on any mild case, you go in for a conservative approach. NSAIDs are given only for severe pain, but it's effective. But as she's pregnant, we avoid, because after 32 weeks of gestation, it is definitely avoided because it causes a premature closure of the ductus arteriosus. So NSAIDs are the NSAIDs should be avoided. In the second trimester, if the patient presents with a moderate or a severe disease, they're good surgical candidates, you should do cholecystectomy in the second trimester, because the recurrence may become higher in the third trimester, where the surgery will become more difficult. In the third trimester, it is better to always be non-operative. You reevaluate the patient after delivery, and you give her strength to like stabilize after the delivery, and you can plan for a cholecystectomy after 6 weeks. What is Bouveret syndrome? So in a gallstone, so whenever the gallstone, so I showed you the path where it enters the second part of the duodenum and it goes and obstructs, right? So Bouveret syndrome is an obstruction of the gallbladder at the level of the duodenum. The other common, these are less common locations. So when it obstructs the duodenum, it is called Bouveret syndrome. Sometimes it obstructs the stomach, and both of them may present with features of gastric outlet obstruction. So this impacted stone may lead to necrosis and perforation and may follow peritonitis or form of fistula. Regarding management of gallstone ileus, how is the incision made in the bowel? So longitudinal incision made distal to the zone of impaction, transverse incision made to the stone. Longitudinal incision is made proximal to the impaction of stone, and without incision, stone is pushed into the colon. So the answer is, so we'll first discuss gallstone ileus. So gallstone ileus, infrequent complication. I showed you the pathway, how it comes from the ampulla of water to the major duodenal papilla, goes to the duodenum and transfers up to the terminal ileum. So it is an infrequent complication, occurs only 0.4% people. An impaction of one or more gallstones within the gastrointestinal tract, more commonly in the elderly and the women. So they present with, they usually follow an episode of acute cholecystitis. And what happens is the inflamed tissue may get eroded. So cholecystintestinal fistula, whenever there's an erosion and the inflamed tissue, a cholecystintestinal fistula may form. So majority usually passes through the intestines. But what happens when the size is 2 to 5 centimeters, it may get impacted. So mainly it gets impacted the terminal ileum or the ileocecal valve. Why? Because it is a relatively narrow lumen and there's a less active peristalsis that is present there. So it is more common for the formation of a fistula formation. So what is the ubiquitous finding you see in a gallstone ileus? So what are the findings that you can see? In an X-ray, you can see a partial or a complete intestinal obstruction. Pneumobiliar or contrast material can be seen in the biliary tree, and aberrant ring calcified or a totally calcified gallstone can be seen. So whenever there's something very famous called a tumbling sign, whenever the change in position of the gall, when you take serial films, the change in position of the gallstones can be seen. So CT is considered superior to plain radiograph or ultrasound. It has a sensitivity of 93%, and it also shows an abnormal gallbladder with air fluid level or fluid accumulation with an irregular wall. So how do you manage? So first, primary management of intestinal obstruction. Then surgical management is enterolithotomy. So you have to you remove the stone from the bowel. So longitudinal incision is made and the anti-mesenteric border and proximal site of impaction. And then the stone is slowly brought through the to the non-edematous segment of the bowel by gentle manipulation and extracted. You should not resect a cholecystoenteric fistula unless the patient is stable. And there are the residual gallstones may cause infection or recurrent ileus. So coming to prophylactic cholecystectomy is advised in all of these conditions except stone greater than 2.5 centimeter, sickle cell anemia, long common channel, porcelain gallbladder, and diabetic patients. So this is a very important classification that you should remember. So the answer is basically diabetic patients. So also 2.5 centimeter, I know you might be have it out, but 2.5 centimeter greater, you should operate. That is larger. Here I know they've given 3 centimeter. So when there are large stones, there is stones in the CBD, there are chronic hemolytic conditions where the pigment stones are formed. The polyps, there are GB polyp, which is greater than 1 centimeter. There's a risk of malignancy or a suspicious of malignancy or an anomalous pancreatic duct drainage. And there's a porcelain gallbladder, and certain ethnic groups or subjects living in high prevalence areas of gallbladder cancer. That is Northern India, Native Americans, Mexican Americans, and others. And transplant patients, especially during the transplant surgery, and patients who are planning to undergo bariatric surgery. So before cholecystectomy, you have to prepare the patient. So you have to take an appropriate history. You do a full blood count. You do renal and liver function test and a prothrombin time. You do just a radiograph and electrocardiogram. You give an antibiotic prophylaxis, that is second generation cephalosporin. You give a DVT prophylaxis. You take an informed consent from the patient that the patient is aware of the procedure being undertaken and the options and risks involved. So cholecystectomy is laparoscopic or open. So we'll first begin with the laparoscopic cholecystectomy. So the position is usually supine, and pneumoporous peritoneum is established. It may be either by the open method or the closed method. Open method is a subumbilical cut down with direct visualization of the peritoneum to place the initial port. So this is the subumbilical cut down. This is a 10 port is usually used as a camera port. This is called an access port of the initial port. In the closed technique, we use it in a Palmer's point, where we introduce a varus needle, induce pneumoperitoneum, and then move forward. We can use a Palmer's point. We can do it here also. And usually the camera that is preferred is a 30-degree telescope, angle telescope is preferred. The other ports are a 10 right hand working port near the epigastric region. This is the midclavicle region, another 5 left hand working port and a 5 port. This is used for grasping the fundus and lifting up the gallbladder. So the patient is then placed in a reverse Trendelenburg position and rotated to the left. This exposes the fundus of gallbladder. You take the fundus, then retract it towards the diaphragm, and then you can see the neck of the gallbladder is then retracted towards the right iliac fossa. It is pulled down. So then you can see the Calich triangle. So the need for doing all of this is to expose the Calich triangle, because that is the key. You have to identify and do a safe dissection of the Calich triangle. And following that, you have to identify the cystic duct and the cystic artery. Only 2 structures, that is the critical view of safety. Only 2 structures seen in that region, that is the cystic artery and the cystic duct. So the gallbladder is separated from the liver bed for about 2 centimeters to allow confirmation of the anatomy. You can use an ICG fluorescence cholangiography. Then after proper identification and dissection, you can, the cystic duct and artery are clipped and divided. The gallbladder is then removed from its bed by sharp cautery or cautery dissection. Once free, it is removed via the umbilicus in a retrieval bag. You can remove it by the epigastric port also. So in open cholecystectomy, only when patients have some contraindication to laparoscopy or the approach is not indicated, or you have to convert from a laparoscopic approach, any inadvertent injury, you do an open cholecystectomy. So you can, the different incisions that you use are an upper midline, a Cocker incision, or a right upper transverse incision. This is a Cocker's incision. This is only very famous for open cholecystectomy. So it is centered over the lateral border of the rectus muscle. The gallbladder is adequately exposed and packs are placed on moving the hepatic flexure of the colon, the duodenum, and the lesser omentum. So you can clearly view the anatomy of the porta hepatis. So again, the peritoneum is divided close to the gallbladder. The Calich triangle is dissected carefully, and the cystic artery and the cystic duct is viewed, and only those 2 structures must be viewed in that plane. And the cystic duct is cleaned down to the CBD, and both the cystic artery is tied and divided, and then the cystic duct is tied and divided. The gallbladder is then dissected away from its bed. So recently, single port laparoscopic cholecystectomy has become famous, but and it has been said to decrease postoperative pain and improved cosmesis. But a lot of systemic reviews have reported a higher failure rate and longer operative time and increased blood loss without any substantive benefits of this technique. So the following are risk factors of a difficult cholecystectomy, except So previous multiple attacks, high ASA score, EHPVO, or a multiple GB stone. So what do you think are risk factors? So multiple GB stones are only risk factors. Following are high risk factors for CBD stone. So what are the high risk factors for CBD stone? When will you diagnose a patient to have a CBD stone? Jaundice, yes. 2 into normal times of LFT, yes. CB diameter greater than 10 millimeters. Greater than 10 stones is usually not a high risk factor for CBD stones. So these are the risk factors for common bile duct. So risk of stones is low, medium, and high. That is what. So whenever there's a history of cholangitis, there's a risk. And when the liver function test is abnormal, that is elevated greater than 2 times of normal, and the ultrasound abdomen, there's a dilatation. The CBD diameter increases beyond 8 millimeter. And a further evaluation, you have to do an MRCP in both. Whenever there's a medium risk and a high risk, you have to do an MRCP with or without an ERCP with a stone extraction. So red flags during laparoscopic cholecystectomy are the following, except failure of timely progression. This is a risk factor. Anatomical disorientation, difficult to visualize operative field. This is always a red flag. And instrument malfunction. So the red flag is no, it's not a red flag, is instrument malfunction. So these are the previous answer. The risk factors for a difficult cholecystectomy is history, physical examination, laboratory test, imaging, and intraoperative findings. Whenever there's a shrunken gallbladder or the liver ridge is attracted with the fissure, depression, or there's a fatty, firm, and cirrhotic liver, there will be a difficulty in retraction. So there's something called a B-safe method in laparoscopy. We mentioned earlier when I showed you the R4U line. So what is this B-safe method in laparoscopic cholecystectomy? It uses the following landmarks except. So bile duct, Rovius sulcus, hepatic artery, and duodenum. All these four are used except for the portal vein. So it uses live anatomical structures. So it is like a cognitive map during dissection. So the things which you saw, that B stands for bile duct, S for the sulcus of Rovia, A is for the hepatic artery, umbilical fissure, and the enteric or the duodenum. So important operative steps that may help you during cholecystectomy are proper retraction. You have to look out for all the red flag signs, especially failure of the timely progression, anatomical disorientation, or difficulty in visualization of the operative field. You have to achieve the critical view of safety. You have to definitely achieve this. And then exposure of the cystic plate. This happens when you separate the gallbladder from its liver blood to expose at least medial third of the cystic plate, and you separate the gallbladder from the fossa. Right. And then, so when you separate the gallbladder fossa, you may have, you have to avoid bleeding from the liver sinuses and liver sinus, and you have to avoid bleeding from the liver sinus and any bile leak. Right. Thank you. Thank you for your patience listening.
Thank you so much for the session, ma'am. I hope everyone found it very useful. We'll meet in many more sessions in the future, ma'am. Thank you so much.
I couldn't hear that.
Ma'am, can you hear me, ma'am?
Yeah. Shall I
Yes.
stop?
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am.
All right.
Okay. Yes, ma'am. You stopped the live, ma'am.
I stop the live.
Yes, ma'am. Yes, ma'am. Stop.